Welcome to this ASN Kidney 360 podcast. My name is François Jouret. I'm the head of the Division of Nephrology at the Academic Hospital of the University of Liège in Belgium, and I'm delighted to introduce my colleague, Dr. Justine Huard.
Good morning, everyone. I work as a nephrologist in the team of Professor Jouret, and I am the co-first author of the manuscript recently published in Kidney 360, which is entitled Impact of Elective Ligation of Arteriovenous Fistula on Cardiac and Renal Functions in Transplant Recipients. First, Professor Jouret, could you please remind us what hypothesis inspired our study?
Well, kidney transplantation is regarded as the best kidney replacement therapy for patients with end-stage renal disease. Unfortunately, before being transplanted, most patients need to be dialyzed, and for those who chose hemodialysis, arteriovenous fistula, also called AVF, is the preferred vascular access. Therefore, a significant number of kidney transplant recipients do have an AVF, which is useless after kidney transplantation. However, the management of a functioning AVF in a kidney transplant recipient with stable renal function remains highly debated. And that's the main reason why we launched this prospective study. Justine, could you please summarize the main results of our study?
In our monocentric study, we have prospectively included 43 kidney transplant recipients, and we have investigated the impact of the surgical closure of a functioning AVF on blood pressure levels, as well as on cardiac and renal functions. We have observed that the ligation causes a reduction of left ventricular hypertrophy, which is associated with the decrease of the serum levels of NT-proBNP, a classical biomarker of cardiac dysfunction. Still, these positive impacts on the cardiac parameters need to be mitigated, since we have also observed an isolated increase of diastolic blood pressure levels after ligation of the AVF. Interestingly enough, no significant change in eGFR slopes after AVF surgery was found in our study.
This clinical observation suggests that the AVF ligation induces cardiac morphological changes by modifying the global hemodynamics of the patients. Indeed, the rationale of an AVF in patients under chronic hemodialysis is the creation of an high flow status to facilitate and improve the flux during the dialysis session. The low resistance associated with the presence of a fistula may also attenuate the arterial stiffness and wall pressure. As an example, the creation of a central arteriovenous anastomosis has been proposed to treat uncontrolled hypertension following such a physiological hypothesis of reduced vascular resistance. Therefore, one may expect that the surgical ligation of the fistula rapidly reverses this status of low resistance high flux, which decreases the cardiac output and favors the rise in diastolic blood pressure and impacts on the remodeling of the left ventricular cavities. In turn, cardiac function improves, as confirmed by the drop of serum levels of NT-proBNP after AVF ligation.
It is interesting to note that these hemodynamic changes are rapid, since we do observe significant impact on cardiac morphology and function as early as 6 months post-AVF surgery, and they persist over time, with a follow-up of 4 years in our study.
Justine, how do you envision the design of our next study about this topic?
One of the remaining open questions concerns the effect of AVF ligation on eGFR decline. In a previous retrospective study, including 114 kidney transplant recipients, a significant acceleration of eGFR decline was observed over the 12 months following the closure of a functioning AVF. By contrast, in the present prospective study, including 43 kidney transplant recipients, no significant difference was found when comparing the eGFR slopes before versus after AVF ligation. The limitations of creatinine-based estimated GFR are well known, including the evolution of the muscular mass and serum creatinine levels or the nonlinear intra-individual trajectory. Therefore, it would be interesting to perform GFR measurements before and after AVF surgery in large multicenter prospective studies in order to better assess the effect of AVF closure on kidney function.
Thank you very much, Justine, for this interesting suggestion. We have to admit that although our cohort is the largest prospective one studied so far, we decided for ethical and pragmatic reasons not to include a control group in which no ligation of the functioning AVF was performed. This obviously represents the main limitation of our work, although previous studies have clearly demonstrated that, as expected, the preservation of a functioning AVF does not change the hemodynamics of the patient within such a short period of time, corresponding to 6 to 12 months. Additionally, we lack the prospective measurement of the fistula flux at the time of the surgery.
I fully agree with these limitations of our study. As a whole, the transplant community needs scoring scales to standardize the management of a functioning AVF in kidney transplant recipients. These scores would include various parameters: kidney function, cardiac morphology and function, blood pressure levels, and the fistula flux. All of these parameters would be interpreted according to the personalized global cardiovascular risk of each patient. For now, the surgical ligation of a patent fistula should only be considered in kidney transplant recipients with stable and preserved renal function or in patients at high risk of cardiac failure. A careful monitoring of diastolic blood pressure should be recommended in these patients after surgery.
Thank you, Justine, for this interesting conversation, and thank you all for joining us for this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.